weird mood. Who knew? Okay. So I'll show you over here on the blackboard. This is we're going to do the blood vessels here, and I'll do the finish the heart and do respiratory for the lab, and then after that it's all systems. After that it's digestive, urinary, repro, and we're done. You don't have me to kick around anymore. So here, as you just go below Unit 3 on Blackboard, you'll see the heart and blood vessel outline, which I had before, but now you can see it again because it has a physiology part on it. And this is the 2 lectures that are on blood vessel phys, and we will start there. So that begins our presentation for today, the physiology of how blood makes its way around of circulation. And I mean, a lot of this is from the Dr. Buxton School of Physics, and as we know, I don't do physics. So we know how it is. We measure it in milliliters per minute. That's important. That whole minute thing is always very important because we talk about the minute volume of air when we look at respiratory, cardiac output, as you will come to find. Certainly on Monday is measured in milliliters per minute. There's a lot that goes on with it. So it's equivalent to cardiac output, and the two have to stay coordinated. The one thing about it, we've got whatever the heart's pumping out, we've got to move that much around. Relatively constant, but in any given moment it varies, and it's all about, and that's what Firefly is about. Be able to increase it dramatically if necessary, and be able to redistribute it if necessary. And that's kind of all we get into. Not today, that'll probably be more addressed on Monday. That's in the next PowerPoint part of this sequence. And so, and again, this is more of a force measurement in physics. We obviously use the term millimeters of mercury. That's the classic. So when whether you're doing it digitally with some type of device or you're doing it the old-fashioned way, basically it's millimeters of mercury. Okay, and really the goal is to get it. It's based on proximity to the heart. So really, we're more upper extremity, even lower extremity could be used. Certainly in the thigh, even in the leg. And really, it's all about the pressure, higher or lower. It makes perfectly good sense. Resistance. Resistance is multiple factors that are there. So certainly the thickness of the blood, we talked about that a little bit in blood. Remember, as the relative number of red blood cells, called the hematocrit, increases, the blood gets thicker and harder to push around, makes your heart work. So normal viscosity is what's needed. If it's very thin, the heart's almost confused. It almost slows itself down unnecessarily when maybe it shouldn't, because then you're dealing with anemia and things like that. When they talk about total blood vessel length, it's not an isolated vessel. And as you'll see, we'll look at not just there's one aorta, but we can look at different kinds of distributing arteries and finally arterioles. And because of that, it's not the individual diameter, it's the total diameter that really is the way we appreciate blood vessels. And because of that, you might remember seeing this diagram where when you get to arterioles, the diameter is small, but we still have muscle, and that's really where circulation is controlled. And so too, blood pressure is controlled. If we can squeeze and close off those entrance pathways, it forces it elsewhere. And that's really where blood pressure is controlled, as you will see graphically in the arterioles. The same way when you get to respiratory, where breathing is controlled in the bronchioles, because we can constrict them or dilate them. Let's say what happens with someone with asthma or bronchitis. I mean, now that's the distinction. How can we alter? I mean, the bronchi, they're you can't squeeze those. If they're squeezable, I mean, someone's choking to death. That's so here's the viscosity. Greater the viscosity, the less able things can move around. Increases resistance. Total length, the longer the vessel, the greater resistance encountered, and diameter. The greatest influence, that the inevitable. What's the greatest influence on resistance, and so too blood pressure, arterioles, particularly their diameter? Because these things don't change a lot. lot, and, other than the illness. So, and again, we talked about that a little bit. It's called laminar flow. Fluid close to the walls is more slowly. We typically find the white cells there. That's how they get latched onto with inflammation and pulled out. And of course, I just heard this on the pit from last week, because they actually did this. What happens when resistance varies inversely with fourth power of the blood vessel? So if we double the radius, okay, the radius is doubled, the resistance drops to 1/16, 2 to the fourth power. So when it opens up, it really, because of the geometry, that's really interesting. All right. So the big problem with small blood vessels is the radius is changeable because the muscles themselves, even though there may not be that many of them, can certainly overcome the amount of, let's say, structural material that's present and squish it. Basically, it's a flexible tube. It's pretty hard to compress an artery. Your blood pressure, in order to take your blood pressure, you're compressing the brachial artery. You got to crank that baby up, and typically from a woman to 180 to 220 millimeters of mercury, depending on the person. At the very least, the old school is take it up over 100 about what your anticipated blood pressure would be. So you're looking at least 220, 230. Dang, that's squeezing pretty tight. And so radius changes frequently. In contrast, larger arteries don't so much. More difficult to do that. So those changes, whether it's atherosclerotic, and those means fatty plaques, again, how many zillion times can I roll that marker along the tabletop and show you what laminar flow is? And the whole thing, that creates turbulence. Turbulence slams the formed elements together, and they have an alarming tendency to start to clot. And then you're in trouble. I worry so much about folks who don't pay attention to this. Because there's someone in our orbit who should be paying more attention to their particular problem. It's not. That has come to our attention recently. And as you get older, that's going to happen to you. You're going to go, why is this person doing this when they know they shouldn't be doing it? So, I don't know what they're doing with that. I don't know what they're doing with that. Forcing, see Dr. Buxton if you have any questions. I'm sure he'll be delighted to answer them. Just tell him you love Liverpool. He'll be your best friend. So as we know, the heart generates blood flow. This is obvious stuff. Just reading it to you to get pressure results when flow is opposed by resistant, highest, and declines. This is a chart. These are so think of the average. We always use 120 over 80. I tell her this is a snapshot. You'd have to do blood pressures daily or twice daily at different times, set up a graph, calculate the averages to see what they are. Anytime you do a blood test, a blood pressure test, an electrocardiogram, whatever the test is, it is a snapshot at that point in time. So to get a true picture, you have to do these on a more frequent basis. Did anybody ever have to wear a Holter monitor? Yeah, Holter monitor. Yikes. Pardon me for that, yikes. Let me just respond to this. Okay. A Holter monitor, when they don't know, and this can be for younger people, when they're not sure if there's something going on heart-wise, they tape this monitor for 24 hours to you, and it continually monitors your cardiogram and other factors that are there. And what you do is you document what's going on with you. So what happens is it's like, whether I just had lunch or I had dinner, I went to the bathroom, those kinds of things. They'll tell you exactly what they are. And you keep that document, and then you put a timestamp on each one when you're doing it. And then they take this off and read it. My son, who just texted me, you might remember me telling you, no, it was a couple of classes ago. They thought he had one of these tiny holes like Crystal Tang has, this foramen ovale in his heart between the two atrial chambers. They were really concerned that maybe that was accounting for all of a sudden he's just losing it. He's a relatively healthy, not even 40-year-old guy at that time, and so he had to wear one of those for because they sent him to to the cardiologist. It's odd for somebody under 40 to do that. But all that aside, this is what you're seeing. This is the pulsatile area. Notice what happens as we enter the arterioles and exit the capillaries. Look at the precipitous drop. This line, as you will come to see ever so shortly, is called the MAP, mean arterial pressure. That's really the critical number because there's a lot of variation top or bottom. So, and I'll show you, do the same calculation also. So if you have 120 over 80, you measure the difference, which is 40. You divide it by 3, figuring that the relationship is just the way they do the calculation. How much time is basically at the systolic, the higher end, the pumping end, versus the resting, and that comes to roughly 13.33. We know that number. You add 80 to that 13.3, and you get effectively rounded off 93. That's the mean arterial pressure. That's really the average pressure at any one time. And that's really important. As long as we keep that in a range, our kidneys will get enough blood supply. It's a great word that you're going to learn. It's really important. The organ has to have enough blood flow. We talk about it being perfused, well perfused, poorly perfused. And if it's not, in the absence of adequate perfusion, the word is ischemia. It does not have a sufficient amount of blood flow. So you need to those are really important terms. Perfusion and ischemia, or ischemic, whether you put it in an adjective or a noun sense. Trying to think of a way to make an adverb out of it, but I will that ischemically challenged. No one cares, Lou. They don't think you're funny. So, like any tube, it's got to be stretchy. I mean, think of the balloon. What do you do before you blow it up? You stretch it. So we have to have something that has a certain amount of stretch, particularly close to the heart. And we talked about it a little bit before. And we're going. This is the area where we really see where it plays a role when we start looking at blood flow exiting the heart, what we call the cardiac cycle. And you're going to see this stretchiness really plays a significant role because when it stretches, there's a rebound phenomena. And these larger arteries, that's why we call them conducting arteries, because they really help to conduct and push the blood flow along. It's all good news and bad news. The good news is they help push it along. The bad news, it's got a lot of elastic fibers, and if they get damaged, it's not good. So you'll hear about it. And coincidentally, this is one of the thing that was missed on the last episode of the PID, which I didn't. We didn't have the technology then that we do today. It's called an aortic abdominal aneurysm. And I mean, that's like a giant bubble in the tire in the worst possible place. And it's, they keep bugging me from UPMC. It's like, oh my God. And they keep bugging me about, oh, you have to go in and get this screening done. And they tell you how much it's going to cost. But somebody over, I think, 60 or 65 is supposed to get that done periodically. Right? I'm fine. I'm bad. But really, there's a lot of tests that they want you to get. So blood pressure in those areas where it's near to the heart, we have a heartbeat. When the vessel's big enough to expand, to stretch, and bounce back, it's effectively what it is. The systolic pressure, okay, the big number is effectively the vast majority of blood, and that's what we're measuring. obviously not the blood going to the lungs by way of the pulmonary circulation, has to have impart a sufficient amount of kinetic energy to effectively open the back pressure that's pushing. Remember the valves that are there, because you learned about the anatomy. You had the aortic and pulmonic valves. Well, the aortic, you have to overcome that residual pressure in the tank to open that valve, and the pressure basically starts at 120. So you got to pop that open. And when you're completely at rest, we're not worried. We just want to know the resting pressure in all the vessels, and by far and away the most important number of them all, the diastolic. So systolic, remember, when it's basically contracting; diastolic, when it is relaxed, or it's resting or relaxed. That diastolic is the residual tension, and how it almost signals a degree of wellness in blood vessels. I can't emphasize that enough. That bottom note, we get high when you come in to take a test. Most of you, that systolic jumps up. Okay, it doesn't matter where you're going. Some stressful situation, that systolic will jump up, but disproportionately so, the diastolic stays pretty constant. Maybe the systolic goes up 20, the diastolic will go up 1 or 2, just to give you some idea. That's why it's so important. And so we look at the difference between them, the pulse pressure. When you feed somebody with bounding pulses, big difference. It's not 120 over 80, maybe it's 160 over 90. And you can feel that pulse. You get used to when you feel somebody's pulse. I mean, mine, as far as I'm concerned, well, I feel mine all the time, and I'm biased. It feels fairly normal. Every so often, it feels a little more so than it should. I was quite ill many years ago. You could tell it wasn't very good. It was more faint, or fainter. And when your blood pulse is fainter, you might faint. And so here's the mean arterial pressure. Okay, steady MAP pressure or MAP. Heart spends more time relaxed. That's why we take that third of it and put it toward the bottom rather than the top. So we don't just average it out. We always use the same numbers. It's easy like that. And that's really what this is part of. Really, when we do the vital signs, you're measuring really an internal wellness check on homeostatic mechanisms: pulse, blood pressure, respiration, and temperature. So again, that's a usable quick snapshot. And we would do, and you go to a hospital, typically, I'm sure they're still doing vitals 3 times a day. Maybe a nursing home be a little bit different, but typically in a hospital, your next shift chart, you're going to come in, take vitals, and you look for any changes. So the area where basically you can do this are areas where arteries are sufficiently close to the surface, and even areas where we can compress them if necessary. These are the classic pulses. Some are easier than others. Okay, the classic pulse that we use, the brachial artery, though I might make it a little more medial, is where we put the blood pressure cuff. Remember my pet peeve, putting the cuff in the wrong place. You got to put it there. Some people put it in the back. It's like I want to just don't. Radial artery, typically the one, very easy, base of your thumb to the exterior of the radial tendon. Okay, flexor radialis, flexor carpi radialis tendon over here. Just gently put a couple of fingers on it, and boom, 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 boom. It's there. The brachial artery, you could palpate, but it's right muscle. You could feel it a little bit underneath the muscle, but not as distinctively. The femoral artery, a very useful one in the groin area. You can definitely feel it. That's an access point for catheterization. You have to have somebody who has a stent procedure. You familiar with what that is? Okay. For those that are not, quick teach. Somebody has a coronary vessel that is too narrow and has plaques on it. Nowadays, as opposed to opening it up, if you can avoid it, you try to avoid it. You feed a line. It's called a catheter. And so all the way up and retrograde it back into the heart, effectively into remember where the coronary arteries are. We know where they are based on to learn about circulation. So we know that the access point is immediately after they exit the aortic valve. And so you can actually, with expertise, feed a catheter in there under visualization because the catheter is radio opaque. You don't see it when you're doing it under direct visualization with, say, continuous X-ray, called a CR. And then when you get there, you feed, eventually it's like a little balloon that you can feed over, something that will inflate like a balloon and squeeze it. And you can then, it's almost like, the stent's kind of like a hair roll, an old style hair roller, rather than the hot rollers like my wife uses. And it's kind of like what we used to call, I know this is pejorative, a Chinese finger trap. I know it should be an Asian finger trap. You know what I'm talking about? Those little guys, yeah, kind of like that. So it's kind of got that, like my old. Remember, I grew up in the days where gals, my mom and sister had high hair, very high hair. Oh, shut up! Nobody thinks you're funny. And so that's where I came up with those. So that you use that as an access point. We used to have to do a cut down when we had died blood. Addicts, you couldn't find a vein for love or money, and you do a cut down there, or their circulation collapsed, and we have to feed one in. So you use the vein. Okay. So it's an important access point. Popliteal is large behind the knee, hard to feel. I always have trouble. And the ones that are relative, a very easy one, posterior tib, right behind the medial malleolus, very easy to feel. Dorsalis pedis, the trouble is it's not that large, and if you press too hard, you can compress it. Very difficult to feel, I think. But those are classically, I would say the best one would be the radial and posterior tib. And up here, we certainly use the carotid. That's the one you typically use with CPR. Superficial temporal, you see with people with headaches. I never had any luck with a facial, but maybe you will. And so, there's lots of ways to do it. We use the sphygmomanometer is just nothing more than a pressure auscultating means. You use that. The name for the sounds is carotid cough sounds. Not doing any of those things. So pressure when the sound first occurs, blood starts to spurt through the artery. So that's typically when we get the systolic pressure. And the diastolic is when the sounds disappear, because in between that first sound, and sometimes you can't hear it if it's very, very low and they're tending towards shock. That first sound, you go, oh, it's 80 systolic. That's bad. Their map then will be, real low. They're in trouble. They're in big trouble. Their circulation is in danger of collapsing. So those are the kinds of things that you listen for. So effectively, and when it's at 120 to 180, you're able to, it's effectively, as blood's going in there, it's pushing, and it's doing this. It's that extending and compressing type of thing, and those are making sounds. And we listen, so we hear the first heart sound, the first blood pressure sounds distinctive. As it fades away, and we say last time we hear a sound, we look, and now we can calculate what the diastolic is. Basically, that's the way it is. Now, you can do them. If you use an electronic device, that's fine. I do not like the wrist ones. They're okay in a pinch. You got to make sure it's here. People aren't supposed to move. It's a little bit different. I'm lucky my wife liked when I'm coming home. You like things. I mean, she has work for me. So, on the other hand, I'm sorry to put the cart before the horse. Here, when you enter a capillary bed, look how much it has descended as it's worked its way down. Typically, it starts at 35 and ends at 17. That's such an important distinction because we're losing nutrients, oxygen, fluid, but by doing so, when it reaches 17, now you're going to see the residual proteins are going to pull tug, are going to create a tug force that's going to pull fluid, with waste products, carbon dioxide back in. So it's a really elegantly designed system. So high blood pressure would tear them. They're fragile vessels, permeable. And because of that permeability, it's very easy with a pressure gradient for stuff. And again, still, in this case, it's always about gradients. Rather, it's really now the concentration gradient is more about pressure, a pressure gradient than anything else. The veins really don't change a whole lot. They stay relatively consistent. And that's the difference between when you see venous blood. If you've ever seen an artery cut, it pumps. The blood is just is a more red color than a darker red color, more of a distinct, I don't know if I'd say cherry red, but you would know the distinction if you see it. And pumpers are a little scary when you see it. And that's the parlance. We call them pumpers. And so we get to, and this is, remember, my area of quote unquote expertise and interest is veins. So, I say it all the time. Whatever Dr. Dresses is, or Dr. Hillwitz, or whatever, we always go a little crazy about this. And so this is how that 15 or so is not a lot of pressure. How do you get it back up here? We use pumping mechanisms, but it's not as though you're sitting there with a bicycle pump trying to get it back up. Bicycle pump, are you familiar with the concept? So the skeletal muscles themselves are constantly contracted. The big ones in your calf, your abdomen, your chest coming in and out. And you might remember when I drew it on the board when we talked about veins. What happens is it's almost like we're creating a suction type of thing. Because of the way veins are and the valves in the vein ensure a one-way flow. When we take the straw that only can go toward the blue tip, we squeeze it, it pumps it that way. When we release it, the valves here close to prevent backflow. And just like anything else, it's almost like aspirating with like a turkey baster. Now you're fills it up. So you're effectively creating, not only forcing it out, but pulling it in for the next go round. And we see a lot of those effects that are there. It's a siphon, just the way you would siphon if you had to siphon gas out of a vehicle or into a vehicle. And maybe you've had to do that. Sometimes you get stuck. When we're breathing, same deal. We're squeezing, that chest, it's more than just expanding the chest, the blood vessels there. And we always have what we call underlying sympathetic tone. Okay, the muscles they're talking about, remember, the muscles are controlled by the sympathetic nervous system in blood vessels. The parasympathetics have nothing to do with it whatsoever. So those are important to recall. And they're just showing you the valves and pushing what we call the column of blood up. And then as you can see, once it's up, as these release, this will slam down, and effectively you'll create that siphon or suction pressure. And the heart works the same way. Just pushing one out, as it pumps, it pushes blood out, and when it relaxes, it pulls the blood, through the superior and inferior vena cava into the atrium. So, how do we regulate all of this stuff? I don't know. Why don't you tell us? Sure. That was a rhetorical question. I figured I'd answer it. Do you always answer a question with a question? Do I? It's a joke. Try that on a test. When you get one of those essay tests, like philosophy or one of those types of, and they have you some broad-based question. Well, to answer that question, let me ask you a question. It's a great way to start one of those things. It's to me, that is something we like to call that condensing the vapors of knowledge in such a way as to make them real. Or the other word is a BS artist. Philosophy class, they love instant A's. That was fascinating. I never looked at it that way. I know. you needed me to be sort of like your studying mentor. So cardiac output, peripheral resistance, and blood volume. Those are the critical pieces. How much the heart puts out, the resistance, that bottom number, and the amount of blood that's in there. And really, it's all about those factors. And they go through these things and all this type of stuff. And I don't care about all those numbers that are there. But the mean arterial pressure, okay, equals the stroke volume, how much the heart is ejecting, the heart rate, and based on a factor of resistance that will also play a role, because increasing the resistance increases that pressure, although not necessarily desirably. The stroke volume is all about, you might remember this, getting the most important thing about your heart is making sure that it refills properly. That's what we call the end, and we're going to do this in cardiac. And I hate to put it a little bit, the horse a little bit before the cart. Effectively, that's all about venous return. So the big deal I make about venous return over the years, having to wear support socks because I had bad veins and standing for long periods of time, all of that has to do with making sure you have a satisfactory end diastolic volume. Read that as the heart fills the way it's supposed to. The heart rate is assisted by control systems in the medulla. Principally, there's also a little help coming from the bonds and the blood vessel diameter. So we have nervous system controls, hormonal controls, kidney controls. You'll notice the kidney is all about long-term regulation and maybe plays the most important role going on. These are subtle corrections that are made here and there, as you will see. So here's your pressure. As stroke volume and heart rate go up, more cardiac output, more pressure. As we reduce the diameter of the vessels, increase the viscosity, the overall length of the vessel, we actually increase resistance, greater pressure. So the mean arterial pressure, blood vessel diameter is the big player in that. So for instance, the way we are designed, if for some reason you would have a drop in volume, an accident where you were bleeding, an allergic reaction causing a significant shock response, even shock of a neurogenic basis. We talk about shock in this particular chapter. And shock is like, oh my God, I saw something that horrified me. It's almost like you're ready to faint. That's neurogenic shock. Okay, the volume drops. There are two areas where we are not designed to have it drop. The heart, which is by far and away the most consistent. Standing on your head doesn't make more blood flow go to your heart. Your heart and your brain. So the heart can alter, and typically in the upside, heart getting downside blood supply. So, and again, this is the idea of redistributing the blood depending on where the need is. When you're sitting here like this, or I'm sitting here like this, our muscles don't need a whole lot. Our brain always gets the same amount. But basically, your genitourinary and your digestive system stay busy. It's the only reason I can explain why everybody keeps going out of the room to go to the bathroom. And the 75-year-old guy sitting here doesn't. No, I wouldn't dream of it.
I didn't even go to bed.
Hmm.
I only got my keys.
I'm too much information. Nobody cares. Okay, and so here it is. So the nervous controls reflexes. This is in the medulla. So and that's why you remember medulla is the lowest anatomical area of the brainstem. Damage there, forget it. School's out, by and large. This is where we start getting into the importance. Baroreceptors, baro like barometer, are pressure receptors. Chemoreceptors are chemical receptors. Pressure receptors are extraordinarily important when we're dealing with this, really. And so when we're talking about blood vessels, it's about pressure. You're going to see when we talk about respiration, the single most important thing is carbon dioxide. And we make our adjustments. Chemoreceptors are next, and then what we call higher brain centers. So baroreceptors, you have a number of these pressure receptors. The two most famous sets are in the carotid. They're called the carotid sinuses, and in the aorta, they're called the aortic sinuses. The most important of these in the chemical are called the carotid bodies and the aortic bodies. The difference is sinus is for pressure, bodies are for chemical sensors. Pressure is more important in this particular system. So clusters of sympathetic nerves, and so this center in the medulla will either, and remember when we're talking here, it will either inhibit or accelerate. Vasomotor means adjusting the tension of the blood vessels. This is strictly sympathetic. They're called vasomotor fibers. Again, motor effectively means muscle, contracting it. And this is the whole idea of what we call vasomotor tone. And all of these other inputs guide this, whether we have to send signals to heart to go hurry up or slow down versus the blood vessels. All right, pressure's dropping a little bit, squeeze a little bit tighter. Let's push this blood a little bit more efficient. It's like a team approach in there. I think you have little people in there. One day you may have to explain this. You may have children who are inquisitive. They may come to you and go, "How does this work, Dad?" Or "How does this work, Mom?" And after a while, you may want to say, "Oh, shut up. Go do your homework. Go play. Go play in traffic." But no, you have to resist this tendency. Tell me you don't want to do that. I always wondered why my parents said, "Lou, go outside." "I'm making dinner." "All right, you can stay here. Just be quiet." Yeah, my mother was a self-acknowledged bad cook. It's, I asked her mom, my grandmother, I said, "What happened? You're a great cook and a better baker." Her coffee cake, tears. Tears, people. And she goes, "I don't know." She goes, "Most little girls want to be in the kitchen. She never wanted to be here." Yeah, go figure. She goes, "Yeah, I'll just eat it." Yeah, absolutely true story. I thought everybody went out to eat like 3 times a week. Just like, I know. Made no sense. Yeah, why do we keep going? We're going here Tuesday night. We go for Asian cuisine twice a week. Why? Because your mom doesn't like to cook. Okay, I got it. Baroreceptors, pressure receptors, sinuses, aortic arch, and carotid. Okay, if it's high, okay, basically it tells those baroreceptors tell the vasomotor center we have a problem. Okay, it inhibits them, slows down the heart, dilates the blood vessel, more about inhibiting, and it decreases the blood pressure. So it's just a pressure sensor, but it's really extraordinary. We used to do this when people were, if their blood pressure would drop, we'd stimulate it. We'd do carotid massage. Okay. And so, you can go in one direction or the other with that. So decreased blood pressure, vasodilation, okay, and the arterioles will reduce it, the veins will, it's just the blood to venous reservoirs, decreasing venous return. That's what it does, and it's really the most important part. And in the process, it decreases cardiac output. Remember, oops, cardiac output basically is a combination of stroke volume and heart rate. And so you're basically inhibiting that kind of activity. And as overall, the dilation of the blood vessels and the reduction in what the heart is putting out is going to mean lower blood pressure. If it's low, it goes in the opposite direction. Okay. And this is real. I mean, this is the classic example of what, and I've talked about it a lot of times. When you get to my age, and well before you get to my age, particularly if you take blood pressure medications, which I do, or other medications, a very common thing we call it itself trade. It's called orthostatic. Ortho means straight, static means not moving. Hypotension. Or postural hypotension, low blood pressure. And every so often, I'll get this in the morning or in the middle of the night, I went to the bathroom, you get up too fast, and it's like, you train yourself. I mean, as you get older, it's like, okay, I'll sit up, a couple counts, get up, nightstand's right over there just in case, and then kind of like, okay. I mean, I'm telling you just what I do. You have to admit I get around okay. I'll be on meet you over at Planet Fitness in Cranberry. I can watch you torture yourselves on the Stairmaster. No, I don't do Zumba. It's bad enough I'm sitting there plugged in with my sport ones and going, no, that's why I know everybody getting next to me. It's freaking crazy.
I don't think anything's as worse as like the ladies that hook themselves up to the bungee cords and like jump around a gym floor. You know what I'm talking about?
Yeah. Oh, it's hysterical. We went to, it's off topic. And so let me finish this. So again, these receptors, there's a fault in those receptors for both of these reflexes. So whether it's the carotid sinus or the aortic, it's just not working properly. That's there. So they're ineffective, and you have problems with the blood pressure. Let me show you I hate this. Okay, the chemoreceptors, aortic arch and lower arteries of the neck detected increase in carbon dioxide or a drop. Really, the carbon dioxide is the big player, both for heart and respiratory. That's the more significant chemical that triggers these. Because when carbon dioxide increases, you're going to eventually cause the pH to drop, and then eventually the oxygen. If the oxygen was responsible, you'd be in big trouble. You're going to see this. So signaling, and what it does, signals the acceleratory center, increased cardiac output, tightens up the blood vessels. So I'll stop it there. But the funny thing is, one of these places, the first gym we went to is called Club Julian. Maybe it's still there. It sits on top of McKnight Road. It used to be the old European health spot many years ago. It's like, if you know where BJ's is now, that they put in there, the old Northway Mall in that area. We went there. She and I, we both joined it. Pool, too expensive. And she goes up to the locker room, and she goes, I can't stand it in there. So all these ladies are sitting around there who shouldn't be sitting around naked. I mean, it's like, she goes, I don't want to see this.
Yeah.
It's like, she goes, I can't stand it up there. It's like, I can only imagine what the classes are like, water aerobics, all those they had, all that side of it. Like, that's when I first learned about one-legged downward dogs. Oh my God. Oh. But the yoga instructor was, I've never seen such flexibility. Goodbye. She was really good, by the way. No, how can she do that? No one can bend like that.